Well, hello everyone. I'm Jamie Tuano. I am one of the neurologists that works at Nationwide Children's. I work in Columbus. And I would like to welcome you all to our afternoon workshop, which today we're going to talk about transition and the transfer process. And specifically, we are going to talk about understanding the unique needs of our young adults and adults with LGS. And so, kind of before we get started, I'm going to lay a little bit of the groundwork. Transition and transfer often kind of get used interchangeably, but I do want to draw a little bit of focus to the fact that transition is the purposeful and planned movement of adolescents with chronic medical conditions, and they're moving from that pediatric, really family-centered care model into more of an adult-oriented healthcare unit. So transition prepares for transfer, but it's really important to keep in mind that transition does not end at transfer. Transition is it's a gradual process. Most organizations, most people recommend that it starts somewhere between ages 12 to 14, and then it continues on into your 20s. We all know teenagers. We know none of us are really done growing up even after we're 20, 21. All teenagers and young adults do need to transition. We are going to talk about the medical aspects a lot today, but it's also really important to be aware of the fact that it also involves legal transitions. There are social, emotional, academic transitions. So really transition is really a very broad kind of all-encompassing topic. We are going to focus more on our youth and young adults with special healthcare needs. So in the US, that is about 13% of kids. We, of course, here are really much more passionate about that 3% that have epilepsy and rare epilepsies. About 90% of young adults now will go through, with any sort of special healthcare needs, do go through the process. They will transition and then need to ultimately transfer to an adult doctor. So in my world, in your world, that's around 30 to 40% of youth with epilepsy. I do want to call out, actually, though, in 2017, the AAP came out with a policy, and they stated out loud that you're not a teenager anymore after you're 20. You're 19, then you're 20. When you are 18, you've become a legal adult. They specifically said that there's really not a point where you no longer can pursue pediatric health care. And I think that's really important. There's kind of a lot of pressure about, when do you have to transfer? And according to the AAP, there's really not a point where you have to transfer. When you transfer to your new adult doctor is when the young adult, their family, and your provider, so the whole team, feels like you are ready to move on to that next level of healthcare. So with that framework, I would like to invite some of our families up to share their transition and transfer experiences with their loved ones.
Hi, me again, Karen Groff here. And I'm sad that my cohort, Natalie Gilmore, is not here today. She's stuck back in New York without all of our LGS buddies, and she was going to be up here as well. So, hi, Natalie, when she finally sees this recording. I wanted to say this is the geriatric session, but I looked around and there are actually a lot of young faces, so that's good. It's just me that's in the geriatric session, but that's because my husband and I have a 38-year-old with LGS. 38-year-old, 6'1", 18-month to 2-year-old. So he's just mobile enough and just verbal enough to get in plenty of trouble, and he's a joy. Thinking back, though, when he was little, much like Tracy, there was no LGS Foundation. There was really no internet. If you got on the internet, it was because you had a doctor friend that could maybe get you on to do a medical search. But it was very, very, very difficult to find resources. And what I would have given at that point to be able to say, oh my gosh, here's a whole community of people. Here's an entire website that has answers to so many of my questions. And yet we were always kind of like on the leading edge of things. Like our buddy's getting old, and our buddy's aging out of school, and our buddy needs guardianship or conservatorship or, whatever. And the resources were not there. Guess what? They're here. And you have a copy of those resources sitting in front of you. Now, the beauty of this resource, and Lori's going to tell you a lot more about it, is that it is meant to be used digitally. But of course, that's not so easy to do in a workshop like this. So we've got a hard copy in front of you. And what would have helped us along the road would have been all these separate chapters and guides and questions and resources about what to do when. And of course, you guys have been in transition probably from the minute your kiddo was born or diagnosed or started having seizures. You know, we go through a lot of different transitions, but I will say the transition from, say, school age and school age programming and pediatric care to the adult world of day programs or no day programs, interventions or no interventions. Now we get to go to a grown-up hospital. Now we need that conservatorship or whatever. That's been a tough one at our house because there was no roadmap. The best I could tell you that we did was we tried to reach out to people within our state that had maybe a kiddo with intellectual delay that we could say, okay, how did you do this? What did you do about that? And our philosophy at our house at that time was, we are not leaving the school world, we're not leaving the pediatric world, we're not going forward with any of this until somebody makes us. Did you, any of you feel kind of like that? I'm going to stay till they kick me out. And eventually, you know, yeah, he finished with school at age 22. And luckily, we had some help from the school district in looking at resources and things. But if you've gone through that, that can be really challenging. You know, now that they're not going to school, what do I do with them? What do they do? How do I keep them stimulated and interested in the world and having a peer group? And by the way, I'm still working and my husband's still working, so you know, what do we do about all this? How many of you have faced that sort of component? Yeah? Yeah. And, you know, around that time, of course, came guardianship, conservatorship, and again, knowing somebody in the state that had already been through that was quite helpful. But it just made me mad. Why do I have to go to court to prove to somebody that doesn't know anything about us, has never probably heard of LGS, why do I have to go to court to keep my kid? To still be his advocate, his mom, his legal guardian, and all that. Well, you just have to get over that, Karen. You got to get over that, and you've got to move forward because having that guardianship's going to open doors. And it did we were slow on the uptake with that, and it did cause us some problems, say in hospitals, you know, where they want to know who's the decision maker. Well, we are. Well, where's your guardianship papers, kind of thing. So that is a component that, in hindsight, I would definitely have done earlier, and I also would have ensured that we got him like a photo ID for the state. He still doesn't have one, but it's on the list. So, whoops. But those are two things that I would definitely go back and say, you know, put them on the list, get her done, just do it. The other thing was that medical transition. You know, the pediatric world is heavenly because they're looking at your whole family, your whole child. If they have, you know, comorbidities, which one of our kids don't, you know, they're more willing to communicate with others. And, you know, we're used to the world of if he's admitted, we're all admitted and we're camping out in that children's hospital, many days in your children's hospital. And in the adult world, we were surprised to find out or to be told that, oh, no, you can't stay with him. We'll have a sitter watch him. And we're like, no. So we're going to have to work out something else. And what we learned along that road was we really need to talk to our doctors ahead of time so that they can kind of smooth the way for us to be able to stay with him, because we would say, you do not have the capacity to keep him safe or your staff safe if we are not with him. So that was kind of a bumpy spot that we did not anticipate at all. When we transitioned out of pediatric care, we had a wonderful team that did help us kind of define, okay, what are our goals with the adult care, and what are we looking for in a team, and that kind of thing. And we landed on a pretty terrific group at Ohio State, the Ohio State University Wexner Medical Center. But what we didn't anticipate is how transient the neurology people were. So we kind of had a doctor du jour, or a doctor of a few months, and then we would transition again, and we might transition again. And how, when we transitioned, did we have any say in who we were going to see and what was going to happen? So we had to work through that as well. And again, talking with other people in our state was helpful to find out, okay, who are you seeing? What's the scoop? But when we saw the first doctor du jour, who we really liked, we thought, okay, this is a fit, this could work. In the first probably 5 minutes, he told us, well, you need to do a surgical eval. He's a candidate for corpus callosotomy. And we were like, excuse me, what? We've been told for the last 22 years or so that he's not a candidate, and we're not even equipped to have this conversation with you. We haven't built that trust. We haven't built that relationship. We don't really understand how this works, and oh my gosh, you're going to cut into my kid's head. So that was a thing, and luckily, we did work through that trust, and we did move all that forward. But it was tricky because in the meantime, we're switching the doctors, and how do we get this eval? And I got feisty and took him back into the pediatric world for that surgery, which I am so excited that we were able to do. But so we were a little bit fluid because of all the transitions. Thinking about what after school day programs, adult, care, what are the options in your area? We got into a stumbling block. Our buddy has LGS, but also type 1 diabetes, which we kind of consider the type 1 diabetes. While it is not fun to have, it's a management issue. And we understand how to manage it. It's tricky with seizures and things like that. But the LGS is, definitely the challenge at our house, and it's what has taken the most away from him and from us. And as we started exploring adult day programs, we found out that they were unable to care for him in many or most of the programs because of the type 1 diabetes. Seizures, no problem. Really? Wow. That's not quite how it goes at our house. But diabetes, no, we can't give him insulin. He needs it to have his life depend on it? No, can't do it. And that had to do with delegated nursing. So we had to figure out, oh my gosh, okay, now what are we going to do? And, all those kinds of things. So how many of you have adult children now that are in some kind of post-school programming or living arrangement? Okay, we have a few of you. Okay, good. So anyway, he attends a half-day program. We settled on picking him up before lunch so that we do the insulin and all that kind of stuff. But it took a little while, and my husband and I aren't done beating on the doors of that. What I really wanted to talk to you about, though, in just the last couple minutes here, is the now what. Danny's 38, his sister is 35, and she's married, and we're going to be grandparents in 2024. And, so we're kind of getting to that place where what if something happens to us for real? And that nightmare you have where your biggest nightmare is something will happen to your child before you, but your other biggest nightmare is something will happen to you before them. It's like the double nightmare. So we're in the process of planning for that and having conversations with loved ones so that we do have a plan in place so that kind of thing can happen rather seamlessly. And our plan, our pie in the sky, we hope this will all work out exactly the way we have it planned, is that he would stay in our house and have around-the-clock care supervised by my daughter and son-in-law. But it's tricky to get that worked out when you can't even necessarily get a nurse to come to your house for a 4-hour shift or an 8-hour shift or, whatever. So we're in the process of all that piece. So now, thank you, UCB, we have this adult care binder that kind of walks you through the walk of all those things, and you can make the best decisions possible for your child and your family. So with that, I'm going to bring up Lori. Oh, back to you to continue talking about the journeys.
Well, thank you, Karen, for sharing. And I think that pretty much she did all of the work that I was going to do, which is good. But I think that it's probably appropriate because a lot of what I'm going to touch on are really things that my families have taught me. And so I think that it aligns well. I think that it's good that my families have kind of gotten us into there he is. There's Danny. At least my families have led me in the right direction. And so as we kind of talk a little bit more, kind of the more nitty-gritty nuts and bolts about transitioning, one of the things that I have learned being in this space as a physician and then as somebody that's trying to build better programming for our young adults is really, I feel like I move back and forth through like these three emotional spaces. It never hurts to quote Fred Rogers. So we do talk a lot about the transitions they're a sign of change, but they also are kind of sad. We're leaving something behind, and I think we all feel that. I feel that when my young adults leave my clinic. I know that you feel that when you leave pediatrics. And then there are days where I think like, we've really got this. We've got something figured out. I've kind of mastered this. And then something brings me back to life, and I realize, I'm just a work in progress. And then I've also learned that in transition, you have to be really accepting. You need to fail fast and then just carry on. And I feel like I move fluidly between these three spaces. So from my standpoint, though I can't imagine how you are feeling as you're navigating with your loved ones. So the problem is that nobody really knows the best way to move through the transition and transfer process. There's a lot of different models. When you look through all of them and kind of do your research, there's a couple of pretty common themes, and so I think those are the important things to focus on. Most people recommend that you start to talk about transition between the ages of 12 to 14. Some people say as young as 10, and that feels really young when you are talking about, kids really just moving into their second decade of life. The other very important thing is these discussions need to happen. A lot of pediatricians don't like to bring it up. Parents don't want to bring it up. They don't want to leave. And so these are things that we need to talk about. And these are ongoing discussions. This isn't something where you show up for your transition clinic visit, you spend 30 minutes, all of a sudden you know everything you need to know and you move forward. It really is an ongoing process. And it does take 10, 12, 15 years. We also need to really recognize that every transition path is really unique, and part of my job in putting together things that will help my families and work with them is that we need to meet families where they are. And how these paths move forward is really determined by what is your epilepsy diagnosis, what's your prognosis, how frequent are your seizures, do you have, what is your intellectual ability? What other medical diagnoses do you have? What other special needs do you have? What do we need to think about? And when we think about our young adult as a whole, what does independence look like for your young adult? So I talk with my families a lot about, independence isn't moving out, getting a job, paying your own bills, cooking your own food. By that metric, I'm not independent. I don't cook my own food. I'm not going to lie to you. And so I think that, that is such a narrow definition of independence. And there are some of our young adults and loved ones that we do need to support them really in all of the areas of their lives. But I think that we also can look at what are those small things that we can help to build some skills so that they do continue to have some growth and take some ownership. And there are small things that all of us can work on and learn. I think it's really important that we take the time to work as a team and find some of those things that we can help with. Then also there are just so many social and emotional factors that are unique to our young adults, to each of our families, that we need to take into consideration when we're doing our transition planning. Maybe. We might not be transitioning off of this slide, so. Oh, there we go. Okay. So, I'm in a room of advocates. I don't need to tell you, but it's helpful to have some information for you to take back to use that can convince other people when you are trying to help them see why transition is so important. So, transition, if it is poorly done and not well planned, is associated with poor health outcomes, and that impacts our youth and young adults. So it impacts the patient, it impacts the parents, it impacts the provider. And it has been shown that if there is not well-structured transition programming, young adults are more likely to have lapses in their care. Some of those lapses are permanent, some of them are temporary. They are less likely to adhere to their medical plan. Some of that is intentional, some of that is because they can't get their medications. They are more likely to use the ER for care, and then their cost of care goes up. For parents, those pieces of independence, it's a lot harder to find those when you show up and your doctor says, actually, next appointment's going to be at your adult physician. You can't find those little things that you can kind of focus on and work on. You can't build skills like that. Parents that don't have time to plan and they don't work with their team to plan are more likely to delay transfer. I think that makes a lot of sense. It is much more stressful. And then also, one of the most common things people tell me when I talk about transition is they come up and they say, it really was like a surprise. We just came in and they said, actually, now you're going to go to the adult side. And that's just, it's not appropriate that that's how it happens. For providers, if I don't work through transition processes, I'm much more likely to delay the care of my patients. We know statistically that especially patients with rare epilepsy were more likely to delay their transfer. I'm much less likely to be well coordinated with my adult colleagues, so that transition and transfer of care is not going to be as smooth. Things are going to get left out or forgotten. There's more likely to have a long wait to the adult appointment and then go back and see lapses in care up at the top, and then also failed transfers. So you make a referral and then our young adults can't get in and they come back and we basically have to go back to square one. So the outcome of a poorly structured transition is, first of all, everyone is unhappy with that care. And then I would take a step further and I just say it's not good medical care. So we really need to do a better job. So then, kind of to build on what you talked about, we have been working really, for probably about 10 years, but working very hard for the past 5 years on building a transition and transfer program where I work with OSU, and we have much more stable neurologists now over there. Yeah. And so I just wanted to talk a little bit about some of the things that I have learned and some of the things my families have taught me in the different areas of transition. There were some of the pitfalls that could have made their processes easier. So in addition to, of course, it being a healthcare matter, transition and transfer are legal issues. And when we are talking about guardianship and conservatorship, it's really critical that you have a social work team and a legal team that is experienced in managing these things. They need to know about the different types of guardianship and different needs for different patients. We do need them to be comfortable talking about end-of-life planning, power of attorney. All of these things need to actually be talked about and addressed by somebody that has some experience in these arenas. Depending on what state you live in, you can start the process at a different time. So in Ohio, we can start it at 17 and a half years. Having said that, if you need to go to neuropsych, the wait list can be up to a year in a lot of places. So if you need to have a competency evaluation, you need to get your referral in for that much easier. And then I did also, you need an ID. Doesn't have to be a driver's license. A state ID is always a good thing. And then also double check your insurance, whether, how long your young adult can stay on your insurance. I also know that these break all the PowerPoint rules. There's too many words on them, so I'm sorry about that, but I wanted to make sure that we touched on everything. So that academic, social, and community support, we have such good networks through school, through communities for our pediatric patients. And between that and then the loss of the social work support that a lot of our children's hospitals have, it's a really big loss that our families feel and we feel as we try to help them move forward. So make sure you're linked with the county board if it's available. The Epilepsy Alliance and Epilepsy Foundation will often have local chapters, and they have social workers that can be like a very nice community touchstone that can help coordinate things. We have wonderful organizations like LGS and resources like the Care Binder that are just incredibly valuable that can help lead you through all of these processes. And then the other thing is that if your youth or young adult with rare epilepsy also has autism, as you touched on, it's very hard to find day programs, work programs that you are comfortable with, where they're well supported and getting the stimulation they need. We know that as much as so many of our kids have good support when they're in the school system, after they become adults and graduate from school, less than 40% of our kids that also have the diagnosis of autism have any sort of community support or programming. So that's a huge loss and really does impact their happiness, but also their outcomes. For our genetic females, we need to think about when is a good time to have cycle control and or birth control, and sometimes that does, of course, impact seizure control. My bias is that pediatric gynecology providers are much more comfortable working with our special needs and neuroatypical young women. We're much more likely to have an effective plan. And you also need people that are really comfortable talking about what are the interactions between hormonal birth control and their anti-seizure medications. And so my bias is that I prefer for that to happen under my pediatric umbrella. So it's an important thing to think about. And then our pharmacy, our pharmacists, I can say my pharmacists are wonderful and amazing and always willing to work with me, but there was a couple unexpected bumps in the road that we came across as we started moving our kids over to the adult system. A lot of my patients, a lot of your loved ones are on specialty medications. And so you need to make sure that your adult physician is comfortable ordering them, that they can still order them, they know the whole process. But also, a lot of my patients fill at my children's hospital. My children's hospital, anyone can fill there, but there are some places where you can only get your medications at the specialty pharmacy if you are a patient at the children's hospital. So these are things that we need to make sure that you double check before you leave that children's system. At-home deliveries are an option for a lot of my patients right now. It's completely amazing. So see if that is an option. It doesn't hurt to ask. And then one of my biggest pet peeves just in general is that pharmacists say we reached out to your doctor, and what they mean is that they sent a fax, which who faxes? And drugs are too important and refills are too important to send over a fax. But what happens is if my adult colleague that is taking over doesn't reorder everything, when the refills run out, they send a fax back over to my office. And then I may or may not get it. It might also go to GI. So when you leave your pediatric hospital, make sure that you call for your own refills and remind your adult physician to please reorder the medications so that if there is communication from the pharmacy, it goes to their office. That was a big learning curve for us as we move forward in this whole process. So now a little bit more kind of nitty-gritty as far as the medical system. Try and get a personal recommendation and a warm handoff from your pediatric neurologist, which I know is what everybody wants, and it's also very hard to kind of get, but see if you can find someone that they like, that they trust. That warm handoff you mentioned in the binder, see if your adult doctor is willing to come over to one of your pediatric appointments, which is lovely. That's kind of the dream. I do talk about a couple other ways where maybe you can have that more personal connection at the end of our talk. Kind of to your point, as you are approaching that time where you may transfer, double check with your physician. The options for surgical epilepsy have changed. So find out if you were evaluated for surgery in the past, should you be reevaluated? Is that an option? Is that a consideration now? Is it time to update your MRI and EEG before you go? Once again, my hospital is much more likely to successfully complete an MRI and EEG on a neuroatypical patient with rare epilepsy than an adult physician is. And then get them on discs so you can take them with you if your doctors don't have full access to that. And then not to say anything, I love my adult colleagues, but there are just things that we are more comfortable with. And this morning we talked about the genetics of epilepsy. It's kind of a similar story. If your genetic evaluation either didn't have an answer or is more than 5-6 years old, at least ask your physician if there is new technology, should you have another evaluation, and if your young adult or family members would benefit from genetic counseling, have that done in the pediatric system. We're just much more comfortable with genetic epilepsies and inheritance of genetic epilepsies in the pediatric world. As far as subspecialty coordination, once again, this is one of the things that people call me and they literally say, we don't know what to do with this neurology patient because they have too many other doctors. And I was like, well, I guess you came to the right place. And so med peds doctors are an incredible resource. They, of course, they walk on both lines. So if you can find a med peds doctor that is comfortable taking care of your young adult, they are wonderful. A lot of places have a complex care doctor that is kind of willing to be your quarterback, or in my case, a lot of time it's me that is helping to quarterback. How do we get all of our specialists ideally at the same adult hospital so that communication is better? If you happen to you might be like hospital, that unicorn that has a transition planner, which would be amazing. We don't actually have one, or sometimes there's a social worker that's really motivated that can help to get appointments at with all of your new specialists. But try and collect them, collect them all, try and make sure that you have ideas for everyone. A lot of our young adults do need psychiatry, psychology, and behavioral support. Those can be probably, for me right now, they are more challenging to find than a neurologist that I trust. For depression, anxiety, sometimes ADHD, a lot of adult neurologists are pretty comfortable with those diagnoses, but some of the more complex behavioral medications you might need extra support with. But that's a really important piece of the puzzle that sometimes you have to work out separately. So when you are looking for your adult neurologist, we know statistically probably 15 to 20% of people say they're really comfortable taking care of our young adults with rare epilepsy, but they want to learn, they want to do better. But kind of what we need is we need them to be comfortable taking care of rare epilepsies. We need them to be comfortable and able to write our specialty medications. And then the other really significant bump in the road is the ketogenic diet. There's not as many adult programs that work with the keto diet. So if you are very comfortable with keto, your young adult has been on it for some time, you may be able to figure out something where you still talk to your pediatric nutritionist and your adult doctor knows what labs to order. You might be able to cobble something together, but that one is a challenge. And I think we were talking earlier, Facebook keto is not epilepsy keto. And so you have to be aware of the people that say that they're comfortable with keto and make sure they know what kind of keto we need. Office logistics are really important when you're looking at an office, either as a neurologist or a primary care doc. How long does it take to get in for an appointment? How do you reach your doctor during the day? How do you reach them at night? And if we are having a rough day, if we just need to be in a quiet space, we need a little bit of time, or we've been waiting too long, how do they know how to help us to calm our young adults that might be having a rough time? Will they room us early? Do they have a room open? Will they let us go back out to the car and call us when it's time for our appointment? How are they willing to work with us so that we can actually have a successful appointment? Also, find out what they need as far as medical records in order to take care of your young adults. So my preference would be I would print out every note that I've ever written, I would give it to them, they would read it all, and they would just move forward and take care of my patient. That's probably not reasonable. And also my pediatric colleagues and I were terrible at creating transfer summaries. It's just, we are. So find out from your new doctor. Do they want 1 MRI, 2 MRIs? Do they want the disc, which I assume they do? Do they want the disc with the brain waves? How many notes do they want? How many labs do they want? Get a sense for how far back do they want to go. And then you can give them that. They can ask you the rest of the questions and then get the whole picture. Because unfortunately, our kids have a long history. We can't really ask them to read every word, unfortunately. And then hospital system issues, which once again, you also mentioned. Some pediatric neurology practices will let you stay until you're 30, 40, 50. But if that is the case, that's lovely. But can you still be admitted to the children's hospital? So some places you can only be admitted until you're 21 or 22. So it's an important question to ask. And then also at my hospital, we don't have a mandated date of transfer, but some of the other subspecialties do. So I am able to keep my kids until I feel they're ready, but some services will move them when they're 19. And so I need to start to think about those things. The adult hospital, do they have your medication on formulary? If they don't, will they let you bring it in and label it for use? And is that going to be okay with them? Do they have visiting hours? Will they let you stay all night? And also, like, my pie in the sky is, can you get a tour so that your young adult knows what to expect if they do end up being admitted? I just think, like, we get tours when when you're pregnant, you get to go tour the maternity ward. Why couldn't we take our young adults in so that they can see what a hospital room looks like at this new site? And I think that it's worth asking, and the worst thing that they can say is no. So that's my dream. Just a quick blurb about some of the limited successes that we have had as we've been working through this process. We have a transition and transfer clinic that we run with OSU. We've been about 5 years now that we've been up and running. We have a longitudinal transition process. So the education happens as you age, and it starts, with prompts we give them written material, and then the electronic medical record reminds the doctors what they should be talking about. So ideally, when they are ready, then we refer them to our transfer clinic, and one of my colleagues from OSU comes over, and they spend a whole day with us, and they meet all of their new patients, who are my patients. They meet them all at Children's Hospital, so they're still there with the familiar faces, the familiar rooms. They have our pharmacist, our social workers, all of those people that can kind of help tie up any loose ends. And then when they leave, they're told, you are an adult OSU patient now. Your next appointment will be on this day at this time. We make sure that they have their appointment scheduled before they leave our visit, because that was really one of the significant pain points that parents identified, was they could not, if they did manage to get somebody on the phone, then they'd say, oh, well, our next open appointment is in 8 months. And so we've been able to really take care of that by scheduling them before they leave. And we also introduce them to our local Epilepsy Alliance social workers, so that they have somebody that they can work with to continue to build that social network we've talked about. Now, of course, not everybody wants to go to OSU, so I do have some kids that have transferred to some of our private practices in town. Maybe the only gift that COVID gave us is we are a little bit more facile with digital communication. And so what we do for these kids when they are going over to a private practice is we have a 4-way Zoom call. It's myself, my young adult and their parent, their new neurologist, and then a social worker from the Epilepsy Alliance. I also do enjoy it because, as like an adult and a parent of a teenager, it's kind of fun to make the teenagers just mildly uncomfortable in a Zoom call. It really is. It's kind of a fun call. But the other benefit is that then the family kind of hears me basically sign out their loved one and what we have been through to their adult doctor. The parents they provide additional information, additional insight, things that I might have forgotten or overlooked. We get to see the pets, we get to meet the cats and dogs because they're at home. And then, once again, before we get off of the call, we make that follow-up appointment. And our other clinic we were able to study because it's a little bit more formal. This one I do not have the formal statistics for, but in talking to my partner that I transferred them to, she said that the follow-ups have been virtually 100%. Families and kids feel much more comfortable coming in. So this is one potential option, because it's really hard to get it's really hard to get adults and pediatric neurologists in the same room for a long period of time. But this is like a 10-minute Zoom call, and it seems like this is something that a lot of people are open to. So I just wanted to share it as a possible, path to some additional that personal recommendation and more handoff. So transition, I think probably, it is fluid, and it is always a work in progress, which I think is appropriate. What I have learned is that a successful transition needs a lot of preparation. It requires a lot of resources, and it requires a lot of multidisciplinary support. I could not get any of my kids ready if I did not have other people with other expertise that could help. Thinking about kind of the 5 key things that I think have led to us having some success at my center. We always are very aware that everything has to be individual. We have to meet our young adults and our families where they are and help them kind of form their own path. We need a willing and skilled adult neurologist that will accept our young adults and help take care of them. See what you can figure out as far as a warm handoff. I think that's really incredibly helpful and is recommended in your care binder as well. If there's any way your pediatric office can help you schedule that first follow-up, that has really been a huge leap forward for us as far as getting everybody into clinic in a timely fashion. And then really what Karen talked about, it's so important to leverage all of your resources and your whole parent network and to build that community support so that you and your young adult have support once you leave the pediatric system. And I'd like to thank you all for coming and for the opportunity to talk and work with you. And then I'm going to hand off to Lori, who's going to talk about her amazing resource that she's created.
Hey there. Good afternoon, everyone. If you can just give me a minute because we're going to switch laptops here. Ooh, yay, it's working. Woohoo! So anyway, thank you so much. I'm Lori Bailey. I'm with UCB. I am the Patient Advocacy Lead for Rare Epilepsies. Many of you may know me. I've been working in this community for many years, probably 8 or 9 years now. I want to thank Dr. Tuano and Karen for sharing. Karen, for your stories. And I wish we could clone you, Jamie, because what you're doing is amazing. And listening to her speak and explain all the things that you have to do, you have a lot on your plate. It is very challenging. It is very, very complex. And where do you even start? So I'm really excited to bring you the Care Binder. So this was a collaborative effort because, as you know, it takes a village to care for your children, and it takes a village to create resources like this. We collaborated with the LGS Foundation, the Dravet Foundation, TSC Alliance, and other organizations and people in the community to bring this together for you. And we didn't start from scratch. What we wanted to do was go out there, see what was already existing, rather than reinventing the wheel. So we did an exhaustive amount of research, and where we could find existing resources, we worked with organizations who generously allowed us to adapt those resources. And so about half of what you see here in the binder are existing resources, and about half is what we developed from scratch. So I also want to mention that, while this is a very comprehensive resource, it is not the end all. It is not the magic bullet. It is not going to have everything in here that you're going to need to get through this journey. But what we do hope is that it'll be a really great place to start. So in front of you, you do have a printed copy of the binder. We wanted to make sure that you had something in your hand during the workshop today to look through. If you don't have one in here, you can raise your hand, and Karen can grab one for you and get that to you, or somebody. Yeah, thank you so much. Thank you. So this resource is really meant to be an electronic resource, and there's a reason for that. Things don't stay static, first of all, and you have a lot of documentation that you have to capture, and so we wanted to create something that you could capture all of the information about your loved one, and then also be able to go back and edit it and update it as needed. So I want to first of all show you where you can find the Care Binder. So it's on the LGS website. If this works. If you go to New to LGS, right here to download the Care Binder, it'll take you to a dedicated page that the LGS has on their site. When you scroll down here and click the Download Care Binder, it'll actually take you to the UCB site, VIP Rare Care. So please take a look at that site when you have a moment. It will also give you additional information on what the binder is about and how to navigate it. And then you can click here to get started, and when you click that button, let me just see here. I tried to have all this teed up. It will pull up the Care Binder, but one of the first things you want to do is just get it downloaded to your hard drive. The purpose of this is having it on your own personal device, because as you add information into the binder, you want to make sure that it's on your own, your own device, so that you can keep your information secure. There is no registration that you have to put in. This resource is freely accessible. So once you get it downloaded, you're going to have this PDF. So I'm just going to kind of walk through this a little bit with you. Okay. So in the first couple of pages, it's going to talk about how to navigate the guide. It's 143 pages, and I know that seems a little bit daunting because it's not even everything that you need to know or have to do. We try to add some navigation tools in here to help you so that as you get through the binder, you can keep your place and see where you're going. You can use Adobe navigation, but it's easier if you use these 3 little tools that we put up here in the upper right-hand corner. Of course, next page, previous viewed, and then this handy little tool, the little home button, takes you to the category menu page, and we'll cover that in a minute. And then if you click back, you can go to the previous view. So what is really cool, and one of the things that I like best about this binder is that as you go through it, you're going to find these little icons. So if you click on the heart icon as you go in here, it's going to give you access to a video, and you'll recognize this person, Tracy Dixon Salazar. You'll have a video in there from another caregiver who has walked in your shoes. And so these little short videos will give you guidance, it'll give you words of comfort and helpful tips as you navigate this binder, because we really want you to know that you are not alone in this. If you go back, let's see, if you click on the blue icon, it's going to take you to a video message from a healthcare professional who takes care of children like your loved one. And so again, these videos will give you words of comfort and helpful insight as you go through the binder. One of the things that you may notice on here is that in the bottom right-hand corner, the page numbers are all missing. And that's because this is not one size fits all. All of you are going to have different individual needs. You're all at a different place in your journey. You live in different states. There are different guidelines. Everything is going to be different. Your institutions have different guidelines. As you go through here, pull out the pieces that are pertinent to your particular situation. You can create your own care binder. So that's why those pages are missing. Well, not missing, but fillable. So the first thing that we really recommend is, no matter where you are in your journey, start with the care guide. So the care guide is kind of a little bit of a roadmap to get you through this journey. Again, everything isn't going to be on here, but we really try to be thoughtful to think of all the major things that you may come across. Also keep in mind that we wanted to make this applicable to everyone. So as I mentioned, in each one of your states, information will be different, guidelines will be different, and so you won't find state guidelines in here, but you may find resources to access guidelines for your state. We worked really hard to put this together for you, and we're really proud of this resource, but honestly, the best resource that you really have are the people in this room, in this community. Reaching out to other people who have walked in your shoes is really, really important and helpful. So I just wanted to reiterate that. So as you go through the care guide, there will be a little bit of an introduction. On this first page, it talks about what approaches that we're taking in the care binder. So this was actually born, it was an expansion of the VIP sibling project, which you may be aware of. The resources are also posted on the LGS Foundation website. They are resources that support caregivers and with siblings that are under age 18. It's been very well revered and very valuable in the community, but adult siblings came to us and said, what about us? One day we may be in the position where we are taking over the care of our brother or sister. What can you do to help support us? And so in talking with the adult siblings, we did a lot of background research. One of the main concerns that they had was that they have watched their parents all their lives take care of their brother and sister, and they know how hard it is. And so one of the things that they feel uncomfortable doing is taking their brother or sister through the medical transition from peds to adult. And so they said, one of the things that you can do to help us is to help our parents get through that medical transition. So when we started putting these resources together, we decided to focus on 3 different areas. One is the medical transition, of course, peds to adult, also long-term care planning for ages 22 and beyond, and then as well, planning for a transfer of primary care when primary caregiver is either temporarily or permanently unable to care for their loved one. And so those are the 3 areas that this resource will focus on. So as you go through, there'll be an introduction into transition planning. And then really important, starting on page 7, is a checklist, starting at age 13. And as Dr. Tuano mentioned, you want to start having these discussions early and often. And so you'll see in this checklist every year when you're meeting with your physician, or even more often than that, if that works for you, is to have those discussions. And one of the first things that you want to confirm is within their practice in the institution where your loved one is receiving care, what are their guidelines? When is your child going to age out? You need to know that up front so that you can work backward in the timeline and make sure that you're having a smooth transition. Because as Dr. Tuano mentioned in her presentation, the longer you wait, the more difficult it's going to be, and it's going to be more challenging because then you're going to be rushing, and you want to it is a long process, so you want to take time to get through it as smoothly as you can. So if you go through the guide, starting at age 13, you're going to see a number of items on here on a checklist to help you identify the things that you need to take care of in the order that preferably that you need to take care of them. And it's not just, as Dr. Tuano mentioned, talking about the medical transition piece, it's all the other things you have to think about. It's guardianship, legal matters and financial matters and all those things, special needs trusts and all the things that you need to think about in order to have successful lung care planning. As you go through the guide, you'll see that there are a lot of links in the guide. Some of them will click on to another place that's internal. So in this particular case, there's a caregiver assessment on medical transition readiness form. And this form will help you work with your healthcare provider to determine when is going to be the best time when you and your family, your child, are ready for transition readiness. So click that back arrow and get back where you are. There are also links in here that'll take you to external websites. So wherever possible, when we mention a resource, we have a link to take you there so that you don't then have to take another step and go out and Google it and try to figure out where you're going. So we hope that you'll find that useful. So as you go through the guide, again, each year there are going to be a list of items that you need to make sure that you're covering. And I want to encourage you that, so this list starts at age 13. Even if you have already started transitioning, go back and look at the list and see if there's anything on there that you may have missed, because certain things are connected to other things, and if you skip a step, then it could trip you up later on. All right, so let me just go through here. I'm just going to get to the end. After you go through the checklist, it takes a deeper dive into long-term care planning. It talks about putting together a letter of guidance and what you need for that. It goes into financial and estate planning. It talks about ABLE accounts, guardianships and conservatorships, and then alternatives to guardianships, because a guardianship might not be appropriate for everyone. Again, this is not one size fits all. And then housing considerations. We heard from Karen. In Karen's plan for her son and her family, they want to keep their son in their own home and provide care for as long as is possible. But for some families, you might be considering residential living. You might be considering other alternatives. So you really want to think about what that future plan looks like. And it's good to think about that plan before you actually need to enact that plan. I was speaking to a parent a few weeks ago at another workshop, and she was sharing that she suffered a stroke. She's a young woman, and she suffered a stroke and didn't have a plan. And it was very, very difficult and very, very challenging for someone else to step in her shoes. Now, fortunately, she recovered. She's doing wonderful. She's great. But for those, 3 to 6 months while she was incapacitated, it was very, very difficult for her child to receive the care that she very thoughtfully provided all his life. And so one of the things that is so important about planning is that, you know, you work very, very hard every day to provide the absolute best care for your child. And so you want to continue that consistent care no matter what happens. And the best way that you can do that is to prepare. So think about that as you go through your housing. This also talks about advanced decision making. These are not things that we want to have to think about, but thinking about them in advance when you are not in a crisis is going to help you when that time comes to be able to face that with as much confidence and calmness as is possible. So anyway, so that's the care guide. And then I just want to talk a little bit about this category menu. And Karen, keep me honest because you know I could talk forever, and I want to make sure we have time for questions. So this category menu goes through all the different sections that are in the guide. You can click on a section to get more detail about what is included in that section. And hopefully the areas that we will focus will help you with the planning, not even just the planning, but how do you even start having conversations about the planning? Because a lot of people struggle with this. For example, if your adult siblings are going to be part of the future plan, how do you have those conversations? It's very sensitive. It's a hard topic. I also want to recognize, too, that even though I've mentioned adult siblings several times, we do know and recognize that every family does not have adult siblings. But you do have somebody in your network, whether it's going to be extended family or other people in the network that you have built, the community that you have around you. And so these tools can be applied to anyone that's in your network. So how do you have those conversations? You can go through here and read about how to have those conversations. And if you go through, if you've noticed, this is a fillable PDF. So you can go in here and prepare for these conversations. Write down what you want to say so that you have this with you. So the other sections that are really important, although I want to mention in the conversations, the having conversations with healthcare professionals. That's another really great one too. Be prepared. As you know, your physicians have a very limited amount of time, so having a guide to maybe collect the information, collect your thoughts together before you go in will be very helpful. There's a daily living section, and as you go through here, you might think, oh my gosh, this is like so crazy how detailed this is. But remember, if someone else is stepping in your shoes to care for your child, how are they going to know how your child communicates? How are they going to know how you feed them at mealtime? Do they have a special cup or a spoon that will get them to eat when they need to eat? Or is there a certain way that you have your kitchen set up so that you can keep them safe? You have pool noodles on the edge of your table, or you have a special mat in case your loved one has a drop seizure while they're eating, or all those different things that you just do without thinking because you do this every single day. But if someone else needs to care for your child, they don't know those things. And so that's why it's important to get everything documented. In some of the areas, depending on what it is, you also have the option to upload photographs. So maybe your child does a specific expression when they want to express, that they're in pain or that they're hungry or something like that. You can take a picture and upload them to help anyone else who may be caring for your child. And when somebody steps up to care for your child, it may not necessarily be because you are incapacitated or in some way not able to care for your child. You may choose as a family to put your child into a residential living place where they have other people that they can engage with and live in a community. And those people, and you may be just down the road, but the people that are in that facility who are helping your child, they need to know these things too. So let me just go back here, get back to my handy menu. So there's the whole section on daily living, and please don't forget to check out this respite and self-care section, because you can't take care of your child if you don't take care of yourself. And I know people tell you this all the time, and it's like, when do I find the time? But this section is really important because it talks about how to recognize caregiver burnout. And so if you have an opportunity, please go through there and check out that section. There's also a section on safety. Then I also want to talk about the disease management. There are so many things that you have to take care of. You have seizure action plans, you have medical care team, contact information, medical equipment, insurance information, what's the medication schedule, supply refills, things to avoid, what are the triggers that your child experiences, right? You want to capture that information as well. And then I want to point out that there are some links that when you click on here, it'll open up an attachments section. So if there is not enough room on the form for you to capture the information that you need, you can find additional pages in the attachments section so that you can add them to your binder. Or if you want to, for example, create an individualized seizure action plan. So all of that can be found there. So I think I'm going to stop there because I'm afraid we're going to run out of time for questions. It's 4:09. We have about 20 minutes. Okay. I'll just mention the other important sections, the important contacts, the long-term care planning. There's a resource section, so there are many resources that maybe are mentioned not within the document, but you can find them in the resource section. And I also, I did want to mention one more thing because Dr. Tuano was talking about the medical files, right? You guys probably have a file this thick, right, on your loved one, and you can't just walk into an adult physician office and hand them a thick binder like this. That's not going to work. So several healthcare professionals did work together and created this epilepsy living in history form. And so it's a summary that you can work with your healthcare professionals to complete, which has a really very consolidated way to report the information on the history of your child. The other thing I just want to mention is when you save this to your own device, you can also save it with a date. I know a lot of people want to keep history. So, if you have updates you want to make, save as and put the new date, and then you can always go back and look at the history if you ever need to do that. And you can also print certain pages to a PDF and email them to people. So I hope that this will be very flexible and give you a tool that not only you can use to help you through this journey, but also to document everything that you need to share it with your healthcare professionals and other people in your support circle to make sure that everyone in your support circle is providing the best possible care for your loved one. So I think with that I will stop because we'll open it up for questions. And I know we have cards on the table, but we forgot to tell you, and so we'll just skip that part, And I also forgot to ask, which I think would be interesting to know. First of all, is there anyone in this room who has a child that's under 13? I'm just curious. Under 13 years old. Or 13, okay. This is good, you're getting a good thumbs up, you're getting a good start. Anybody with children between 13 and 15? Has anybody started the transition process? No. A little bit? Okay. Yeah? Well, you're here, right? You've all started because you're here. You get that counts. What about like between 16 and 18? Ooh, lots of people. Okay, and have you guys started your transitions? No? Yes? No? Sort of? How about over 18? Okay, lots. And dare I ask, have you started the transition? You have lots of, I see a lot of nodding. Okay. Has anybody completed? Oh, it's never complete. Well, that's true. That was a trick question. Well, let's open it up for questions for Karen, Dr. Artuano, or myself. If you have any questions, please raise your hand. Feel free.
We have 2 mic runners, and please wait for the mic before you ask your question.
Why is whenever we transfer them over, why the people accepting them, their wait list is so long? Like I try to do a dental, it's 2 years.
Oh, wow. That's a question for you, my dear.
So the wait list is very long as far as willing adult providers. And a lot of it is, so at least some of it is a systems problem. For instance, like some adult providers, like adult dentists, a lot of them do not take Medicare, Medicaid, whereas in the pediatric world, I don't think that you would survive, and none of us have the desire to not see Medicare, Medicaid patients. We're pediatricians, we want to see everybody. But in the adult world, they're much more restrictive about what insurances they will accept, and so that can be a problem because a lot of our kids that have a lot of medical complexities are on Medicare, Medicaid. And then it is also like the willingness and the expertise to take on kids that are young adults that are medically complex. Then when you go to a larger academic medical center where you would expect that you would find them, their staffing is limited by how many people they're hiring, how many people are, doing the research that we need them to be doing, so their clinic appointments are limited. So it is a kind of a systems-wide problem. And I think that it does happen in pediatrics as well, but I feel, in my opinion, the Medicare, Medicaid acceptance is really what really makes it much more evident when you move into the adult world. That's multifactorial, as all things are, but that's a major barrier. And so I don't know if, you've come across that.
I'm glad you mentioned wait lists because not only may you have a wait list for a provider, but you may run into issues with day programs, residential living. Get on wait lists for waivers as early as your state will allow, because it can be years long waiting lists.
Yeah, so our pediatric neurologist, we've had the conversation with him, and he said he'll take care of our daughter as long as we want to continue to see him. But it's the other providers that you have to coordinate with. And so he's been very good at reaching out to these adult providers because, like you say, the wait list is really long, and somehow, I don't know, the doctors, they can pull some strings and they can get you in there if you have people that are willing to work with you. And the waiver programs and housing and stuff like you're talking about, we found that has extremely long process. We got the most help in our situation, our state. We're from Washington State. The special needs counselors and stuff in school were the ones that put me on to getting SSI set up in the beginning and to get these programs. And like the rec department in our towns have a specialized recreation program, and that it goes from young adults to 99. You can be as old as you want with special needs, and that provides you another outlet to keep your young people, active and busy and being able to interact with their peers. It has been very, very helpful for us. But I did find that the children's hospital does have an age limit on when they will operate, and so the doctors may have to work into the adult SING in order to do procedures.
Thank you for that. I'm glad that you mentioned that because anybody who's using the care binder, we really want to encourage you to give us feedback or insights or guidance on your journey. We're going to be updating it every 18 months. And I'm trying to see where I have this in here. There's a link on the back page of the binder. There's also a link on the LGS website as well as VIP Rare Care. But we ask you to, as you're using it, give us feedback, give us insights so that we can keep improving it because this is a work in progress. Yeah.
I had a comment to follow up on the dental providers. It took me 5 years trying to find a dental for her after she left Children's Hospital. They allowed her to stay until she was 22, but everybody told me they wouldn't take her because of liability. They didn't want somebody who may have a seizure in their chair. So that was really frustrating to me that, she wasn't allowed to get treatment because of her disability. So now she's at the university hospital where it took a year to get her in. And if you do that, make sure you get your guardianship papers because they will not take them without it.
Trish?
Hey, well, I want to thank you for putting this together. I think it's so hard to imagine, except for the people in this room, how hard it is to navigate so much of this. And I think of myself and my wife, who was an attorney, and 2 dad doctors, and we're in Los Angeles, so there's a lot of resources and access, and it's still so hard. So I think I just want to reiterate that in the things we have to go through, even staying on top of all those things you're talking about, conservatorship, the SSI, and some of it is so stupid.
Yes.
Like genuinely stupid. Like the calls, people are, as my wife likes to say, everyone's trying their best, but sometimes you get these check-ins and weekly paperwork for SSI. You're talking about like a $15 a month paycheck or something. They want to know, the questions they ask you. So I appreciate it. I think people in our situation can use all the hand-holding and guidance, and I want to say thank you.
Thank you. Thank you, Ben. Thank you. Yeah, and I wish we had time to go through everything because we didn't even talk about like the financial piece and what you have to consider and with SSI and make sure, you're careful about the accounts that you have in your child's name because it can keep you from getting services and it's just a lot.
So I had a question for you. I think you mentioned that to transition from, say, like pediatrician primary care, we should look for something called a med ped. Can you describe what that magical creature is?
They are magical creatures, in fact. They are, so when they go through residency, so I went through a pediatric residency to take care of kids. They do 2 years of pediatrics combined with 2 years of internal medicine. And so when they graduate, they have seen everything in both worlds, and so they're a perfect person to take care of our young adults because they have pediatric problems, but also adult problems. And the benefit, particularly that makes them different than other family practice doctors who get some pediatrics or adult medicine doctors, is that they get their training specifically at a pediatric hospital, and so they get exposed to our kids with rare epilepsy. They get exposed to all of the medical complexities just like a plain pediatrician. And so generally, in their bio at the in their wherever they list their interests in practice, they'll call themselves a med peds doctor. A lot of the time they do have a tendency to cohort in the same practice. And so if you find one med peds doctor, there's a chance that there might be other med peds doctors there. And then they do have a little bit more of a tendency to be affiliated with academic medical centers because that gives them the infrastructure. A lot of them still take call on both sides. But yeah, they are wonderful people to work with because they are not, they're not intimidated by taking care of medically complex young adults. So yeah, definitely look for them. And I did not talk about SSI in my, what I was talking, but one of the things that I have experienced is, a lot of my families apply for SSI, and it's, first of all, frustrating. A lot of it is very stupid. But one of the things that is hard, I think not hard for those of us in this room to understand because you are further along the process, but a lot of people will apply when their kids are 7 or 8, and then they get turned down and they think that the case is closed. And you have to keep in mind that as we have kids with developmental disabilities, as they get older, the differences between them and their same age peers become more apparent. A lot of people will apply when they're 4, and I say, well, 4-year-olds are fully dependent for all their care, so I know that your life is very different, but not according to kind of the adult world of SSI. And so 2 things: if you have applied in the past and you were turned down, just keep reapplying. But also there are lawyers that their whole job is to get people SSI because, of course, they generally want to say no. So you may need, like, a specific SSI lawyer can be really helpful for that too.
Yeah, we actually recommend that you apply 1 month after your child turns 18 because in a lot of states you cannot apply before that time.
Me? Oh. I would just like to give a helpful hint since I'm kind of at the end of this whole transition. My daughter's 40, and we've done almost everything that's in this book, but something that has helped me along the way is when I got my guardianship and conservatorship, the court gives you a paper finalizing it saying, yes, you are the guardian. I reduced it and I laminated it and I carry it in my purse. Because I can't tell you how many times you go to a pharmacy or a doctor's office or somewhere and they'll say, are you the legal guardian? Yes, well, we don't have that on record. Yep. And what are you going to do, go home and get it? So I carry one with me in my purse.
Yep, that's very good advice. You should always carry the guardianship paperwork.
So my daughter she's 24. I think all her doctors now we've transferred over. But the one problem that I ran into was when she was with pediatric doctors, they all knew kind of the issues that you have from, birth to 18. Then when we switched to adult doctors, especially some things, they were used to more end-of-life issues, like 60, not even 60, that's too close to my age. Like, 80s, 90s. But I mean, so there's this huge gap. And so I wondered if you had any advice for that. And then just as a neurologist, what kind of percentage of kids do you see that have rare epilepsies? Because like when we're trying to find new neurologists, I had one practically run out of the room when he heard my daughter's history. He couldn't get rid of us fast enough. So what population do we make up like in a practice like yours?
So as far as the medicine problem, that is a very real problem. Typically there is kind of typically there's a drop-off in healthcare kind of utilization from, after kids stop having to go get their shots and all that. And really a lot of internal medicine training is focused on those later in life problems that pop up. And women spend more time going to the doctor than men, and but we go to, we usually get women-specific care. And so that is a very big problem, and they are not comfortable even just taking care of, they're less comfortable, I should say, taking care of even healthy, not complex young adults. They just don't come in that much. So that's where you need your med-peds doctor. But your experience it was real. It was real. But it is a problem because it is, internal medicine focuses on a lot more end-of-life kind of degenerative periods. As far as, I was just trying to think, I mean, in our practice, one of my one of my partners is going to be really angry that I don't know this number just off the top of my head, because he always tells me these numbers. But so in Columbus, of our epilepsy patients, because we are a level 4 epilepsy practice, we are probably at least 50% intractable complex rare epilepsies, 40 to, because we are higher than the average, which we would say in general, 40 to 50 intractable, and then our rare epilepsy is a part of that. But we are in that probably 40 to 50 rare intractable frequent seizure population, just because of how because of where we are and what we do. So when you need a practice, you need to find someone that either has, is at a level 4 epilepsy center, or else, once again, when you go into the bio, someone that has done, so you can technically read EEGs without a neurophysiology fellowship or an epilepsy fellowship, but if you're looking for somebody that's going to be more comfortable, when you look at their bio, look for them, if you're looking for a pediatric person, look for somebody that has done a year of neurophysiology, or or also a year of neurophysiology and a year of epilepsy, because that means that they have that epilepsy focus, and so they're less likely to not be a good match. Does that help? Okay.
Hi. This might be crazy, but so with children born with heart defects, a lot of times the pediatric hospitals will keep them as adults. LGS, these kids get it young, they go on to adult neurologists that do not have the 20, 24, 25 years of experience of LGS they do in pediatrics. They push us out and we go to adult neurology, where she was, talking about that. They deal with strokes, they deal with traumatic brain injuries, the car accidents, not what how hard, excuse me, I'm talking too much, I guess my alarm's going off. And it's a systemic issue, right, that we're all aware of, because you can ask a neurologist, an adult neurologist, you're specialized, but you can ask them, how many LGS patients do you have? And they probably can count them on their hand. Or they'll say something very insensitive like, we don't have much, they don't make it. Is there a way that the LGS community can push to kind of stay in our, is that just crazy to stay like the heart babies do?
So it's an interesting question, because that's one of the major debates that we have at our hospital as well, is kind of, thank you. I'm part of our larger hospital, and all pediatric hospitals. And is one of the debates, is kind of who gets to stay and who gets to go. And the answer is nobody really has the answer. The adult cardiologists are trying to learn more about congenital heart, so they're trying to move those kids. A lot of people reference the CF population, so now the CF population is living longer, the care is better, and so they, a couple years ago, CF said, okay, we're actually going to start to move you forward. And so there has been a lot of talk, and a lot of us do, as ironic as it is, because I do try to do transition to programming, I really drag my feet. I am not the model for getting kids over to the adult side. But I try to do it in early 20s ish. We're just trying to get them ready. But I think that's the big question, and the fear from the pediatric community isn't the epilepsy. We're not worried about the epilepsy. What we're worried about is that I can't take care of adult hypertension. When people flip into AFib, which they tell me is a pretty typical adult problem, I don't know what to do with that. And that's where the pediatric people start to get worried. And so what we need to find is that sweet spot where, we need the adult doctors that can take over our rare epilepsies and do a good job. But we need to find that sweet spot where we can still provide good, safe care, because there is a turning point where I'm not the best whole body doctor for you. And so that's the issue. But it is an ongoing debate. And when we always, we get the cardiology patients are like we are all really worried when we have adults cardiology patients, and also I'm going to tell you that none of the wives like it when we accidentally call them mom. But that's the ongoing debate, is kind of like, why do their kids or the young adults get to stay and mine have to go? So yeah, and I can tell you I'm afraid of true adult problems, but those don't start till they're in their 40s. So like, what's the sweet spot? So I hear your worry, and I drag my feet, but I don't have a great answer for you.
Well, thank you, everyone. I think we are out of time. If you still have another question, please come find us afterwards. But we just want to thank you so much for coming and spending your afternoon with us. And, we hope that you find these resources helpful and that you found this information helpful, and that it'll help navigate this very complex journey for you. So thank you so much. Thank you.